So this is, I think, a rather short chapter for quite a large topic. I've included several readings for this module on D2L to better help you grasp disablement models that I hope that you have already dug into, but if you haven't yet, make sure that you are taking a look at those. We'll discuss more about this when you get into your administration class, but I think in talking about this introduction to disablement model, it's important that you understand what a disablement model actually is. So really what it is it is sort of a standardized language across disciplines. It allows us to look at all the factors, clinician-centered and patient-centered factors, um, and all of the variables that impact the patient from social interaction to activity and so on, and puts them together in one model to make sure that as we look at the patient in the broad sense, that we are taking care of the whole patient and not just the body part or not just the injury. Okay, so it allows health professions to communicate across disciplines and across models when it comes to patients. Now, the profession of athletic training is using and endorsing the ICF model, the International Classification of Function and Disease model. So that is a model that you definitely should pay a lot of attention to. But there's also the Nagy model that we'll talk about and is talked about a little bit more in this chapter and in some of the readings because it was really the first disablement model that was used that really addressed function of a patient. But the ICF model is really the most used model. It's what athletic training and what all other healthcare professions are using. And it helps the clinician, again, see the patient as a whole person and in treating the patient and not the condition or symptoms or injury of the patient. What exactly is disablement? So disablement refers to the effect of a health condition or conditions, and we look at conditions separately, on your patient's body. And I really want to emphasize that, okay? So on the patient's body, okay? It's not your patient. You are not treating the condition. You are treating their patient. You are treating a fellow human person, okay? But along with this, it's also their ability to participate in meaningful activities. Okay, so if we're talking about sports or other physical activities, can the patient do those? If we're talking about someone who is a factory worker, can they do those activities associated with that job? Can they function meaningfully during their daily activities? And in addition, can they perform their desired roles in society? What do they want to be doing with their lives? Right? What were they doing with their lives before they became injured? And are they still able to do those? Right? So also, what are the societal factors involved in disablement? The medical perspective of disability is the view that the patient's disability is a problem specific to the patient and the disability is caused by their health condition or injury. As health professionals, we often have a tendency to treat the health condition or the injury first, and then secondarily, we'll treat the patient's disability by improving that injury or health condition first. Right? So we have a patient with a disability, and we as health professionals treat that injury first. And then whatever we've done with or for that injury, that is what is going to cause that disability to improve. Okay, so that is the medical or healthcare perspective. The social perspective of disability comes from the view that society or the patient's environment is the creator of that person's disability. And for that person to overcome that disability, the environment that they're in or the society that they're within must change to improve that disability. The patient has to overcome the disability to be able to function in the environment or the society must change for them to overcome that disability. So this is saying that the society is the cause or the contributing factor to the patient's disability. If we were to think about this from an athletic perspective, that very well could be, right? Being a member of a football team, right? That's being a member of society. From the social perspective, it is an environment, and we are looking at and trying to change these cultures and environments all the time in order to change the disability or improve the environment for our patients. In combining the medical and social perspectives, we can reach the biopsychosocial perspective. This is an interaction of the health condition or injury, the limitations and impairments, the environment and social factors, all looked at the same exact time. Okay, again, all of these, especially when we look at a big part of our society, which includes athletics and sports, have to change to improve disability. The biopsychosocial perspective of disability allows for the development of an overall treatment plan, right? It lets us look at the whole patient from the medical and social perspective. We're going to look at the origin to the organ or the body part, and then to the person and to the societal factors with the biopsychosocial perspective. The Nagy model of disablement was really the foundational model from which athletic training started looking at disablement models, and it really is probably overly simplistic. It looks at the origin through the pathology, the impairment at the organ level, the functional limitations at the personal level, and it looks at the disability at the societal level. We don't use this because, as you have read, or as I hope you've read, and as you can see from the ICF model, that the ICF model is much more appropriate and omnidirectional rather than unidirectional like this model promotes. But basically, the active pathology is just really, what's going on? What cellular processes have been disrupted? What's happening and how is the patient's body responding to that, right? Because remember, the body is always trying to maintain homeostasis. And to maintain homeostasis, the body may develop symptoms in an attempt to correct these imbalances. So, for example, a fever, right? The warmer our body temperature, the more difficult it is for invading organisms to survive. So it is a change created by the body in an attempt to return to homeostasis. The impairment comes because we have loss of some function or the patient has a loss of some function, right? That system is doing something that it should not be doing. This is where you as a clinician should be assessing, right? So for instance, if we have an athlete who passes out, don't be the athletic trainer who doesn't assess vital signs and you just chalk it up to, oh, well, hey, they didn't eat or drink too much today, so that's why, right? You are a healthcare professional. You should be checking vitals, you should be checking glucose levels, etc., right? To actually and truly assess what is going on and what is causing impairment of the patient. The impairment occurs because there is some disruption of a body system, and we need to assess that patient to find out what is causing that disruption. Functional limitations that result happen on the personal level. Whatever restrictions a patient has to place on themselves or the restrictions that you or some other healthcare provider has to place on that patient change what they can do. If they change their activities of daily living, for an athlete, this would be participating in their sports, right? That is exercise that they normally have as their activity of daily living. If they're not an athlete, this could be getting up out of bed in the morning, going to the bathroom, making coffee, brushing their teeth, right? So what are they? What are their limitations? What are they? This is what the patient really sees and experiences. They may have pain or other symptoms, but they will try something and they're just going to be like, hey, I can't do this. This is what I'm experiencing right now. The disability comes at the societal level. When they can't fulfill their necessary or desired expectations of themselves, or they can't fulfill their normal roles in their lives is where we see disability. So again, for an athlete, it might be their sport. They can't participate on their team. Or for a non-athlete, it might be work. They can't get up and they can't go to work and so on, right? And this is really where the Nagy model comes in. You can see here how it is a precursor to the ICF model, but it's fairly limited. So here on the left, you can see the Nagy model, and then on the right, we can see how the Nagy disablement model is applied. I'm not going to spend a ton of time here because it's pretty self-explanatory. So you can see here how the Nagy disablement model is applied to an ATF sprain. Pretty straightforward here. Now, hopefully after reading about and studying that Nagy disablement model, you can start to see how the ICF model is more applicable to our patient population compared to that Nagy model. The ICF model is used and endorsed by virtually every healthcare profession. But the ICF model is designed to depict decreases in function on the three health domains of body function and structure, activity, which doesn't just mean sports participation. It means overall activity by the patient, and then participation. So participation in sports, participation in social activities, etc. So you can see right from the jump here that the Nagy model is already incorporated into the ICF model. This represents the disability positively by describing the patient's ability to function as opposed to the patient's disability. So again, it represents the whole patient and not the disability that the patient has. As you can see, the Nagy model was very linear. You can clearly see here that the ICF model most certainly isn't. Right? It shows, for example, that the health condition or disease can have an impact on activities, and the activities or inactivities can have an impact on the disorder or the disease. The condition can also have an impact on body systems and their function and on participation, and it goes both ways. Personal factors play a role in activities, and activities play a role in personal factors, and environmental factors play a role in activities, and activities play a role in environmental factors. This is a way to more accurately show us how all of these domains interact with the patient to help us understand the overall impact on that patient. Okay, so much more so than the Nagy model, which is just very linear and unidirectional. So here is really where the ICF differs. We have the health condition at the origin level, so the physiological functions of the body structure and function at the organ level, so the anatomical parts of the body, what systems, what body parts, etc. The activity at the personal level, so the non-social tasks that the individual is looking to execute or have as part of their lives, right? So what tasks can they execute as opposed to what tasks can't they execute? The participation at the societal level. So what is their involvement in life situations and scenarios? If you think of this as an athlete or a physically active person, what activity level are they at? So the individual societal level is based on the patient's society and what they normally are doing. And then finally, the environmental and social factors included in the other domains. So physical, social, attitudinal, personal. All things that will also impact the total care of the individual patient. So we could treat the physiological limitations, we can treat the body part, but what happens if they have a bad attitude, right? What if they don't want to get better, right? So maybe a workman's comp patient who doesn't want to get better. It takes them longer to recover. Why? Because they are getting paid to not work, right? And this has been, honestly, that's been demonstrated repeatedly in studies. So there is attitudinal and social impact here. Athletes even sometimes don't want to participate in their sport. Maybe their team is doing really poorly, and they don't want to just go to practice or be in games just to lose another game or just to lose again, right? Or maybe they're under an immense amount of pressure to participate because maybe they're the keystone of the team, right? They're the guy, they're the person on the team, and they don't want all that pressure on them anymore. So environmental and societal factors play a huge role in this. Now, with the ICF model, we have the same application of this model with the same ATF sprain that we had with the application of the Nagy model. Although it appears linear here, we know from a couple of slides ago that it isn't, right? But we can see here that we start looking at the other domains. Now we can look at the environmental and social factors here. Now the patient has an athletic trainer. Now they have lifestyle and their sport. What's their previous history and how does that interact with their ability to function? How about their participation level and their ability to play the game? And what does that do to their overall healthcare? Both psychological and physiological. The ICF model has input from all of these, and you can see where it looks linear, and I really wish I could draw on this to show you that it actually isn't. But alas, I am not very good with computers, even though I spend almost every day on one. But you can see how these domains impact all the way over to even like the organ level, for example. So you start plugging this into that ICF model that is multidirectional, like the one we saw 2 slides ago, and you'll see that there's a big difference. There's much more being taken into consideration here than with the Nagy model, and it is what the patient can do versus what they can't do. All right, so I hope that this all makes sense. This lecture, I think in combination with the readings I've posted on D2L is a good introduction to disablement models, and you'll definitely get more information on this and more practice in the application of this in the administration class later on in the program.